Hello, ladies and gentlemen. We are starting the lecture for the client that has fluid, electrolyte, and acid base imbalance. Next slide. All right, fluid and electrolyte. So what we are going to talk about first is just the general concept of fluid. All right, intake is very important because intake equals output. Right, intake is very important because intake equals output. And the fluid that we take in, we have to make sure that majority of it is coming out. Right, so intake equals output, which equals fluid balance. So if you are taking the average amount of fluid, which is about 2,500 cc's, we got to make sure that that water somehow is going to come out as well, right? And so there are ways that we can lose fluid, right? So some of those ways are sensible ways, right? An example of that will be urination, defecation, wound drainage, right? Insensible ways are evaporation and respiratory, loss from the lung. All right. So the insensible fluid loss is fluid that is not, it's usually unnoticeable and unmeasurable, right? Unnoticeable and unmeasurable. All right. So the fluid has component, right? There's chemicals, there's the water, there's electrolyte, there's acid, and there's base, right? So the purpose of the body fluid really is to what? Regulate the volume, buffer blood to keep it at its pH neutral, and we're going to talk about what we mean by a neutral pH level. Next slide. All right, so the fluid compartment, there's intracellular and then there's extracellular. All right, so most of the fluid is inside the cell, 40% of the body weight. All right, 60% of the lean adult male is 60% water. So for example, if somebody weighs 100 pounds, 60 pounds of that is water, right? And then you have the extracellular fluid. This is the, 20% of the body. And there's two types of extracellular fluid. You have the interstitial fluid, and that is the fluid between. And then you have the intravascular. That's the fluid inside in the plasma. And of course, your textbook talks about how this varies with age and sex. And that is table 16.1. It talks about how the infant intravascular fluid compartment is 4%, the male is 4%, female is 5%, and the older adult is 5%. So it's relatively constant for intravascular volume. And then you have the interstitial. Look at the difference here. The infant is 25%, right? 11% for male, 10% for female, and the older adult is 15%. So you see the differences there as well. And then intracellular is 48% for the infant, 45% for the male, 35% for the female, and 25% for the older adult. So what you're seeing is that the full-term baby, it's about 80% of the fluid, right? The age adult is about 40% of the fluid. So the infant has more water, so easy for them to dehydrate. The older adult has less water because look, 77, 60, and then 45, according to your table 16-1. So the older, the age as well as the babies they have a higher risk for dehydration, right? Because the need for water is more for the baby, and the elderly already have lower amount, so easy for them to be dehydrated. So we have to be mindful of that. Next slide. So we talked about, again, the average fluid intake is 2,500 a day, which ranges an average of 1,800 to 36. Right? We get our fluid a lot from liquids and some food, so your vegetables, your fruits contain water. And we also talk about that the sources, they have to average out, so what you take in should come out. So the sources of urination we talked about already, as urination, bowel, elimination, perspiration, breathing. And then the insensible ways are the sweat and exhaled air. Next slide. So now we're going to talk about the physiological process, of distribution of fluid and electrolyte. The terminology translocation means the back and forth movement, right? So the back and forth movement of fluid and exchange of, it's to exchange the chemical, right? It's a continuous process, right? And these processes are divided into two categories. You have processes that are passive transport, and you have processes that are active transport, right? Your passive transport are diffusion, filtration, and osmosis, right? And your active transport is requiring the sodium potassium pump. That requires energy, right? Energy. And that energy is referred to as ATP. Let's talk about each one of these processes. Diffusion, right? What is diffusion? Well, diffusion is the movement of, molecules that are moving across some type of barrier, mechanical membrane, okay? And this membrane can be permeable, semi-permeable, or impermeable, and what happens is the molecules are moving, molecules, not solvent, the molecules are moving from an area that has, from a higher concentration to an area of a lower concentration, right? And then the next process is filtration. Filtration is the movement of solute and solvent. Solute can be sodium. Solvent, the universal solvent, is water. So the solute, the movement of both the solute and the solvent across a membrane by the use of hydrostatic pressure. So that's like water pushing. Okay, this happens at the capillary level. If the normal pressure gradient changes, for example, like in the right side heart failure, edema is going to result from third spacing, right? So movement of solute and solvent across a membrane caused by hydrostatic pressure, so pushing of water. All right. Next slide. The next process is osmosis. Osmosis, here there's movement, but what is moving is the solvent, the water, right? The universal solvent is moving from an area of lower concentration to an area of higher concentration. This process is shown in your figure 16.3. You see how where the fluid was, there was less concentration, there's less solute, the little blue like dots, there's little solute. So what happens is the water moves, right? So the movement of the solvent, the water moves to the area, from the area of the lower concentration, and you see how it goes over to the area that has a lot of solute. Okay? And this happens through a semi-permeable. So in order for this to happen, this membrane has to be able to allow things to pass. It cannot be impermeable, right? Active transport, like I said, this is where you, the solvent, the solute, right? The solute can be moved against some type of concentration gradient, right? Called a pump, right? This depends on the presence of energy, right? The presence of ATP. Presence of ATP. Next slide. Well, before I move on to the next slide, let's talk about, the fluid. There's different types of fluid, right? There's isotonic fluid, hypotonic fluid, and hypertonic fluid. All right, so isotonic solution, let's talk about each one of these. Isotonic solution, this solution is a good type of solution because what you see, there's no shift of fluid. Remember when we're talking about area of higher concentration, lower concentration, there's movement, right? Well, with this type of solution, and this is what you want the body to be like, that's what the body is, there's no fluid shift because the solutions are equally concentrated, right? An example of this type of fluid that you may give is normal saline solution. It's abbreviated as 0.9% sodium chloride. That's NaCl. Another example is lactate or ringer. All right? And then you have the hypotonic solution, where hypo means low, right? So it has a lower solute concentration. Right? So when you have something that has a low solute concentration, remember we'll talk about the different processes. So the fluid is going to shift into the more concentration area. Okay? When it moves there, then the cell is going to swell because now you have more fluid in that area. So it swells up. An example of this type of solution is called half normal saline, and that is 0.45% NaCl. All right? And then you have hypertonic solution. With hypertonic solution, what you see is higher solute concentration, right? So what happens when you have a high solute concentration? The fluid is drawn into the hypertonic solution to create a balance, right? So when that happens, the cell is going to shrink. An example of this type of solution is 5% dextrose in normal saline. D5/0.5% normal sodium chloride. All right? So next slide. So now we're going to talk about the mechanism of fluid and electrolyte regulation. The job is to maintain normal fluid volume and electrolyte concentration. And to do so, the body has its own regulation, right? And these types of regulatory mechanism are osmoreceptors, or the name baroreceptors reflex, volume receptors, all right, renin-angiotensin-aldosterone mechanism, and antidiuretic hormone, or BNP. Okay? So let's talk about each one of these. So the baroreceptors, what happens is, the pressure, the arterial pressure, a fall in the arterial blood pressure triggers this response, right? So the receptors sense the pressure change, and then by doing so, the tension of the wall builds up. And these are located, in your arterial walls, vena cava, aortic arch, and carotid sinuses. And so what happens is the arteries, areolas of the kidneys, they constrict. And when they constrict, it helps the body retain fluid. Okay? And then the volume receptors, this is the response to excess amount of fluid. So if there's a lot of fluid, in the atria or any of the great vessels, right, these receptors create a strong renal response that increases urine output. So I have a lot of fluid, then the kidneys say, you know what, we got to excrete this fluid, otherwise the patient is going to get congested, right? The next one is the renin-angiotensin aldosterone mechanism. You all should be thinking, yes, we know this word because renin is an enzyme that is secreted by the kidneys, when the arterial pressure or the volume drop. So there's a drop, and then this enzyme is secreted by the kidneys. The job is for this enzyme to interact with angiotensinogen, right? Angiotensinogen, then they form something else called angiotensin 1. Angiotensin is vasoconstrictor. All right? And when this happens, the angiotensin is converted in the lungs to something else, and that something else is angiotensin 2. In order for it to convert, there's an enzyme that is needed, and that enzyme is called angiotensin converting enzyme. And you should be thinking, I know ACE inhibitors, right? The ACE inhibitors that you give for high blood pressure. So you're trying to inhibit this process for someone who has hypertension, right? This angiotensin produces vasoconstriction, right, to elevate the blood pressure. So someone who has high blood pressure, you don't want this elevated anymore. So that's why we give the ACE inhibitor to stop that process from happening. And then it stimulates the adrenal cortex to secrete aldosterone. Aldosterone, that is the mineral corticoid, and it does control water and the potassium blood level. Right? So it increases the chloride and the bicarb concentration and fluid volume. All right? And then the extracellular fluid and the sodium levels drop, and then it causes ACTH by the pituitary gland to be secreted, and then the release of the aldosterone by the adrenal cortex. And then what happens is the fluid and sodium is held. Right? So it's held, retention. So ACTH, adrenocorticotropic hormone, and that is secreted by the anterior pituitary gland. And then the final process is the antidiuretic hormone. This is also called vasopressin, and vasopressin is released by the posterior pituitary gland, and the pituitary gland is considered your master gland when there's a need to restore the intravascular fluid volume. So the release is triggered by the osmoreceptors in the thirst center of the hypothalamus. Right? Body is really nicely set up. So pretty much the antidiuretic hormone, if you look at the word anti means not, and then diuresis, not diuresis, right? So clearly, we're not supposed to just get rid of our fluid, right? But this hormone is able to sense if you have fluid volume excess, if you have a lot of fluid volume. Because remember, it is antidiuretic, right? So it's not diuresin. So what happens is the level will drop because you want to diurese now. Because if it's still high, then the patient is not going to diurese when they should. They end up having something called, water intoxication. That's the syndrome of inappropriate antidiuretic hormone, right? Because If you're not letting it out, you're just going to hold onto the water, then you're going to have way much water than you need. That's called water intoxication. Right? And if you have fluid volume deficit, that's a nursing diagnosis, right? These are both nursing diagnoses I'm talking about. So what happens is there's an increase in the antidiuretic hormone, right? There's an increase in it because you don't have enough fluid, so I don't want to give up my fluid. Next slide. So now we're going to talk about your fluid imbalances. Fluid imbalances. There are 4 different fluid imbalances. All right, I've already talked about water intoxication. We'll talk about it a little bit more. But there's dehydration, hypovolemia. There's a difference between that. Somebody being dehydrated, someone that has low blood volume. So let's talk about each one. First one is dehydration. Dehydration is a loss of body fluid. All right? It's a loss of body fluid. And so what you see is you have an increase in the concentration of solute in the blood, right? And so what happens is there's a rise. So it looks like the patient, if you look at the blood cells, it look like they have higher level of red cell, but it's because of hemoconcentration, right? Because you don't have a lot of fluid, so you're going to look like you have a lot, but you really don't. So the fluid shift out of the cell into the blood to restore balance. So the cell is going to shrink from the fluid loss and can no longer function properly. There are some folks who are at risk for dehydration, and we should pay attention to that, especially the ones who are confused, who are comatose. These guys cannot get the fluid, cannot ask for the fluid. Individuals that are bedridden, and if they are, they're not able to go and get the fluid. So making sure that the fluid is within reach, if they can reach for it, is really important. Infants depend on the adults. Elderly, they already have hydrated. The infant was already overhydrated, so they really need the fluid. And people that are on tube feeding. So what do we see when someone is dehydrated? Right? What do we see? They are irritable. They're confused. They're dizzy. There's weakness. There's extreme thirst. The urine output will be less. There's fever. There's dry mucous membrane. The eyes will be sunk in. There's poor skin turgor, so which means the tinting of the skin, the recoil, when you pinch it, it should recoil fast. And if it doesn't, that's an indication. The elderly clients, you may not use their hands because it's very fragile. So you use like the chest area. So what do we do then? So you know what you see. So what do you do? Well, remember dehydration, there was a loss of fluid, right? So we want to replace the fluid. And usually you're going to give it oral or IV fluids over 48 hours. You monitor the signs and symptoms and vital signs. You monitor the eyes and nose. Maintain the IV access. And daily weight gain. Skin and mouth care. So for the IV, that's what we have to give. We have to replace the IV fluids, right? So a practical nurse can start an IV, or they can start an IV if they know how to start an IV, if they were trained to start an IV, because some people have like phlebotomy classes, which they would teach them how to start the IV. But once the IV is started, if it's not started by you, then your job is to maintain the IV and monitor the IV for any signs that may suggest a problem. And IV fluids, you can just use a peripheral line. But if it's the central line, that it's already in place because of whatever issue that the patient may have, you can, monitor that as well. So when you're monitoring the IV site, most agencies have a form that you have to monitor and document what is happening to the site. The most common site you see for IV site is an incubator site, right? So usually, you monitor it every 2 hours, or hourly for the children. And you look for things like part of the form that is used. In that, you would talk about your intake and output, like the amount of fluid that they're taking in, plus either all the IVs, all the different devices, drainage devices that they have will go under output. But you're looking for complications, right? Some of these complications are infiltration, phlebitis, thrombosis, cellulitis, and septicemia. So infiltration is the first one, or extravasation. So it's usually the most common cause of that is damage to the wall during the insertion or angle of placement. So your technique is really important, so you have to be trained to do it. Because if there's a proper technique, then there's less chance of infiltration or extravasation. When there's an infiltration, means that it's not in the vessel, right? And it's usually in the vein we're talking about here. So if you notice an infiltration, you've got to stop it. Stop the infusion because it's not going in, right? And then sometimes if, the practical nurse do not give this type of drug, but if you give a drug that is very corrosive to the skin, you have to, there's a drug that you have to inject to the site, and of course the doctor needs to be notified immediately. All right? And then phlebitis or thrombophlebitis, that can happen because of 3 different things, right? Phlebitis, that's PHLEPITIS. It can happen because of a chemical problem, mechanical problem, or bacterial, right? So you have to look at them differently, and your treatment is also very different. So for chemical, it's usually because the infusate, right? The actual drug, erodes the internal layers, right? So a warm compress may help, while the infusate it stop and change, right? So anti-inflammatory drugs may be used, right, to help with that. And then the mechanical phlebitis is usually caused by irritation to the internal lumen of the vein during the insertion of a vascular access device, right? And usually appears shortly after the device. So what we do is the device may be removed and warm compress applied. And of course with bacteria, it's caused by an introduction of bacteria into the vein, and again, immediately we have to remove the device and treat with antibiotic. And generally what you see with this, you see signs of infection. So there's pain, there's redness, there's warmth, there's edema. And cellulitis, this is again the connective tissue, loose connective tissue around the site is inflamed, and it could be caused by poor insertion technique. What you see is red swollen area that spreads, outward in a diffuse circular pattern. All right, so we have to treat with antibiotic here as well. And of course, with septicemia, severe infection that occurs to the system or entire body. It's very, very, very important because of poor insertion technique and poor site care. So we have to provide good care, right? So we have to discontinue the device immediately, culture the area, and then treat. With IV, you may also have something called pulmonary edema because we're giving too much fluid, right? Too much fluid, and so that causes pulmonary edema. You can have pulmonary embolism, something that is free, floats, generally will require thrombolytics over several months. And then air embolism, right? That's caused by air injection into the IV system. So this is why we want to keep the site below the heart, the level of the heart. Okay, so pretty much LPNs, can start the IV. Like I said, LPNs cannot infuse blood product or high risk IV medication. Right? You cannot. All right, so what do? We talked about it already. We're going to maintain the IV access. We're going to do daily weight. We're going to do mouth and skin care. Let's talk about the next one, and that is hypovolemia. Hypovolemia, it is the loss of isotonic fluid from the extracellular space. Okay? It can progress to hypovolemic shock. And what are the causes? Excessive fluid loss from, example, hemorrhaging. Decreased fluid intake. Third space fluid shifting. Vomiting. Diarrhea. Profuse urination. All right, so what do you see? There is a change in mental status. The patient is thirsty. There's tachycardia. So thirst is really, really a good indication. Delayed capillary refill, so it's greater than 3 seconds. They have orthostatic hypotension. The urine output is low. Their skin is cool. And there's weight loss. So what do? Well, we have to replace the fluid, right? Oral or IV. If there's fluid shift, we got to pull the fluid back, and so albumin replacement can help with that. If it's hemorrhaging, we'll give the blood transfusion. Dopamine to maintain the blood pressure. That is a drug that is not given by the practical nurse. Assess for fluid volume overload, right? So 8 to 10 glasses of water if they can have oral intake, right? Restrict the sodium, avoid any beverages that can excrete more fluid, like caffeine. All right, next slide. We're talking about hypervolemia. So hypervolemia is excess fluid in the extracellular compartment as a result of fluid or sodium retention, right? Or excess intake, renal failure, heart failure, adrenal gland dysfunction, circulatory overload. So it could definitely lead to problems. Heart failure, pulmonary edema. What do you see? Tachypnea, dyspnea, because it's in the lung, crackles, rapid, bounding pulse, hypertension, abnormal heart sound, increased venous pressure, jugular vein distension, acute weight gain, and edema. So what is edema? Edema is seen when the fluid is forced into the tissue by hydrostatic pressure. It's usually seen in the dependent areas, right? And a soccer, that's what we refer to as generalized edema. Pitting edema, it is on your figure 16-H, talks about what pitting edema is. Okay, and weight gain, again, is an early indication of weight, of fluid excess. But your figure 16.8 talks about the different grades of pitting edema. It's from +1 to +4. Right, so when you're documenting that someone has edema, you want to use this terminology to describe it. If you say it's +1 pitting edema, you're saying that there is some slight indentation when you touch the patient's skin. It's about 2 millimeter. The skin, normal contour of the skin, right? But when you see that, it means that about 30% fluid above normal. And then +2 is 4 millimeter. It's deeper after you press down, and it lasts longer than the 1+ edema. And then 3+ is even deeper, 6 millimeter, and it remains there for several seconds. Skin looks obviously swollen. And then +4 is even worse. It's 8 millimeter. It remains for a longer, prolonged time after pressing, possibly minutes, and you see frank swelling. So in your description and your documentation, you're going to say 4+ edema area, or the foot is has frank swelling, right? So what do we do? What do you do when there's edema? So, well, they have lots of fluid, so we're going to restrict the fluid and the sodium, right? Right? You're going to give diuretics, monitor the vital signs, monitor INO, the breath sounds, monitor ABGs in lab, elevate the head of the bed, Fowler's position, semi-Fowler's position, maintain the IV access, skin and mop care, and daily weight. Next slide. So nursing diagnosis for fluid volume for hypovolemia is fluid volume excess. Related to what? What is causing them to have excess? Well, are they taking in too much? Intake that exceeds fluid loss, right? So what do you do for that nursing diagnosis? So you need to know the baseline weight and make sure we do a daily weight. And usually weight gain of 2 pounds in 24 hours is indicative of that. So we have to have accurate intake and output. We need to auscultate the lung sounds. We need to measure the blood pressure, heart rate, and respiratory rate, and inspect the skin for edema, cracks, and breakdown. So your documentation, you will say if it's normal without any edema, you could say skin clean, dry, and intact, no edema. All right. Water intoxication, that's the other issue that we talked about. So remember I said when the antidiuretic hormone, it's just holding, it's not decreasing when there's a lot of volume. So the patient will go into water intoxication. So that's one cause. Another cause is maybe because we give excessive water, tap water, with NG2 or enema. So what happens with this water intoxication, the extracellular fluid is going to shift to attempt to restore balance, and the cell is going to swell. So what do you see? Early indication will be things that tell you that the pressure in the cranial pressure is high. So there's change of level of consciousness, there's muscle weakness, there's twitching, there's cramping, and in the late stage, bradycardia, there's widened pulse pressure. So the differences between, the distance between the systolic and diastolic is widened. There's seizure percussions, they have seizures, and coma. So what do you do is to prevent the cause of it. Is it because we're giving too much fluid? Are we giving too much hypotonic solution? Then we need to stop that, right? Is it because the problem with that antidiuretic hormone? We'll fix that, right? Assess the neural status, monitor eyes and nose and the vital signs, fluid restriction, IV access, make sure that is patent. Make sure we weigh them daily, monitor the sodium level, and put them on seizure percussion. Seizure percussion. All right, next slide, we're going to do an example of a question. So, a client is at risk for impaired skin integrity due to compromised circulation related to heart failure. Interventions to maintain intact skin include what? Okay, you're correct, right? Changing the position is not going to help. It's going to help maintain the skin every 4 hours. It's every 2 hours, at minimum, right? Restricting ambulation is not going to help. Keeping the patient's legs lower than the heart is not going to help. So the answer is C, applying the stockings. Next slide. This slide is telling you the rationale for the answer. So elastic stocking supports the valves in the vein and prevent the fluid from pooling in dependent areas such as the feet and ankle. Next slide. So third spacing is translocation. Remember that back and forth movement of fluid from intravascular to tissue compartment? And we talked about that already. Remember, we're saying the patient will want to give albumin. So the reason why the albumin level may be low because the albumin pulls the fluid. Someone who is a burn patient, someone who has severe allergic reaction. And so what you see is edema, generalized edema, ascites, right? So you see hemoconcentration, the CVP will be normal, the blood counts will be borderline. So the treatment for third spacing is giving them albumin to pull it back into the third spacing and IV diuretics. Right? And that's the edema discussion that I just talked about. Okay? All right, so now we're going to talk about, next slide, we're going to talk about electrolyte imbalances. Electrolyte imbalance. Electrolyte imbalance occurs, because there's a deficit or excess, usually accompanied by some type of fluid change. Electrolytes have charged particles in solutions, and these charged particles are, cations or anions, right? Electrolytes are an integrated part of our metabolic and cellular processes. It's needed. There are positive and negative electrolytes. The cations that are positive are sodium, potassium, calcium, and magnesium. And the negative ones, anions, are chloride, bicarbonate, phosphate, and sulfur. We have some major cations. So the ones you probably learn in A&P, the major ones are in the extracellular compartment are sodium, and the intracellular compartment is potassium. So those are very important. So there's different types of electrolyte imbalance. So we have hyponatremia, hypernatremia, hypokalemia, hyperkalemia, hypomagnesium, hypermagnesium, hypocalcemia, hypercalcemia, hypophosphatemia, and hyperphosphatemia. And then you have hypochloremia and hyperchloremia. So hyper a lot, hypo low. So you have this for all the different electrolyte. Okay, so the priority electrolytes imbalance are the sodium, potassium, chloride, and magnesium, and you see why this is the case. Many things can cause the deficit of it. It could be from administration of IV fluids, it could be from vomiting, diarrhea, diuretics, and excess can be from the amount that we consume or parental administration of the electrolyte. Maybe the kidneys are filled, maybe the endocrine system has a dysfunction, they have some injuries and burn. So let's start with our first electrolyte imbalance. Next slide. Sodium imbalance. Sodium imbalance. One thing you have to understand is that sodium helps maintain the normal nerve and muscle activity. So it helps in regulating the osmotic pressure, preserving acid-base balance. Sodium is the major extracellular cation. It attracts fluid and helps preserve the fluid volume, right? It combines with the chloride and the bicarb. This is how it helps to regulate acid base. The normal range for sodium is 135 to 145. You should know these numbers because when they say someone has hyponatremia, it means that it's less than 135. Hypernatremia, it's more than 145. So remember your range. And the lab values varies from different place, but the majority is the same. Okay? So we are talking about, before I go into that, let's talk about a little bit more some help when it comes to sodium in water. Sodium in water. Remember that sodium attracts water. If sodium intake goes up, remember when you've eaten something really salty, what happens is you start drinking water, right? So if the sodium level goes up, extracellular fluid concentration also rise, right, to try to balance things. So you have an increase in sodium. Again, you start drinking more, and then you release ADH. And then it triggers the kidney, hey, wait a minute, she's very thirsty here. Let's hold on. Let's hold up on the water. Aldosterone also has a function in the water and the sodium conservation when the sodium level falls. And then the sodium-potassium pump. Sodium-potassium pump are very, very important. So it's like this mechanism where the sodium and the potassium, they try to remain constant. Because remember we said the sodium is where? Abundant where? Extracellular, outside of the cell. It is always try to want what it doesn't have, which is to go in the cell. Because in the cell, the most abundant one there is potassium. So it wants to get outside of the cell, right? So there's this pump to help maintain the normal concentration. And that's called the sodium-potassium pump. But this pump cannot happen without an energy and magnesium, right? So magnesium is very helpful in maintaining the sodium-potassium balance. So if you have a low level of magnesium, then this pump is going to be affected as well. So this pump is going to help to prevent the cell swelling and create an electrical charge, right? Allowing the neuromuscular impulse transmission. So it's really, really important, right? So magnesium is important. So now we're starting with our first imbalance, so hyponatremia. So hyponatremia is sodium that is less than 135. It could be that somebody is deficient in it because related to the amount of fluid that they have. And it comes in different forms of it, right? Several forms of this hyponatremia. Is it dilutional, diluted, right? Is it depletional? Is it hypovolemic, hypervolemic, or isovolemic? So let's talk about each one of them. Dilutional, right? To dilute. So usually this results from sodium and water loss and water gain. Sodium loss and water gain. So it becomes diluted. I have sodium. I lost my sodium, but I have more water. So I don't have enough salt, right? Or depletional, insufficient intake of it. So your treatment is going to be based on this type, right? Hypovolemic one, where you have the sodium that is lost, is greater than the water that is lost. So this could be from maybe diuretic use or from non-renal, such as vomiting. Hypovolemic, this is water gain, is greater than the sodium gain. And what happens is, this is where you see edema. Remember, we're just finished talking about the different type of fluid volume deficit. Isovolemic, so it's normal sodium level, but it's too much water. Too much water. So what do we see when someone has low sodium level? Well, think neurologic symptoms when you think of sodium, okay? Neurologic symptoms. So they have headache, nausea, vomiting, muscle twitching, altered mental status, seizures, coma. And if it's hypovolemia, so there's poor skin turgor, right? Because hypovolemia, low fluid. Those signs and symptoms. Hypovolemia, remember those signs and symptoms of a hypovolemia that we see? So what do we do? Is it a mild case? But if it's a mild case, then we can say, okay, depending on what it causes, so we restrict the fluid intake. If it's hyper or isovolemic. IV fluids or increased PO sodium intake for hypovolemic hyponatremia. For severe case, we can infuse a hypertonic solution, so 3% or 5% sodium chloride. Remove furosemide to remove excess fluid, so pull the fluid out, and monitor the client. And usually these guys at the severe level, they will be in the ICU. Next slide. So now we're talking about hypernatremia. So hypernatremia is excess sodium relative to the body, often less, occurring than hyponatremia. Thirst is the body's defense for this. I salty, thirsty. We talked about when hypernatremia occurs, the cell will shift outside the body. And this may be caused by many things, such as diarrhea, such as over-ingestion of sodium, less water from diarrhea, high fever, excessive water loss. It may also be from diabetes insipidus, which is antidiuretic hormone, and this syndrome, and the patient is just there's problem with the antidiuretic hormone, and the patient is just peeing a lot. So what do you see? You want to think salt. Think salt when it comes to hypernatremia, because hypernatremia, a lot of salt, so think salt. So S means look at the skin. skin flushed. A is agitation. L is low-grade temperature or fever. T is thirst. And then you will see the other neurologic symptoms that we talked about, right? And then signs of hypovolemia. Because if you have a lot of salt, you may have too less fluid, right? And what do? So hypernatremia is greater than 145, right? So mucus is sticky. What do you do for these guys? All right, so we correct the underlying problems, replace the fluid, but as we're giving fluid, we have to monitor for signs of cerebral edema and seizure percussion, because remember, sodium, neurologic stuff. We may have to restrict the diet or supplement. Okay? Next slide. Now we're talking about potassium. Potassium is very important in maintaining the normal nerve and muscle activity. Very, very important. Right? And it is the major intracellular cation that we talked about. If potassium is untreated, it can cause serious neuromuscular and cardiac problems. The normal level is 3.5 to 5. It's really important to understand that and know your levels. The body balances potassium, right? It does balances potassium. And it does so because most of the potassium that is ingested is excreted by the kidneys. All right, and then there's other ways to help balance it. Remember we talked about the sodium and potassium pump, how this pump uses energy, right? It pumps sodium out of the cells and trying to create a balance. And we also talk about how magnesium plays a role in that ATP, in that transport. Other ways that potassium remain balanced is the renal regulation. So what happens here, if there's an increase in potassium level, there will be an increased potassium loss in the urine. So the kidney, it's important if it's functioning well. Aldosterone secretion causes the sodium and reabsorption of potassium is excreted. Another way that it remains and maintains its balance is the pH level. So potassium ions and hydrogen ions are exchanged freely across the cell membrane, right? And so when you see hyperkalemia, right? Acidosis, you see acidosis, you see hyperkalemia, so the potassium will move out of the cell. Alkalosis, you see hypokalemia, and the potassium moves into the cell. So we're going to talk about the different acid-base balance so you can understand acidosis and alkalosis. So now let's talk about our first electrolyte imbalance, and that is hypokalemia. That means that the serum level of potassium is less than 3.5, right? It can be caused by many things. It could be caused by potassium wasting diuretics, like Lasix and hydrochlorothiazide. It could be caused from the GI tract loss. So either we're suctioning the patient is vomiting, or we have some drainage. Steroids, IV insulin, glucose, insufficient intake of potassium. What do we see when it comes to someone who has low potassium? Well, think the acronym suction. SUCTION, right? Well, the S means skeletal muscle weakness. The U is U wave, changes, right? If it's in your figure 16-8. Okay, U wave changes. Constipation, toxicity of digitalis, so digoxin. Because if you have low level, digoxin and potassium compete at the site. So if you have low level of potassium and the patient is taking digoxin, this patient is going to have more chances of developing toxicity because there's more available room for the digoxin to bind. Irregular, weak pulse. So think heart, that's for I. O is orthostatic hypotension, and then N is numbness. All right, so suction, skeleton muscle weakness. U is the wave, U wave changes. C is constipation. T is toxicity of digitalis, which is digoxin. I is irregular, weak pulse. O is orthostatic hypotension, and N, numbness. So think heart with potassium. So what do? Well, they don't have enough. Maybe it's because of the diet. Well, we increase the dietary intake. Is it because they're taking a drug called Lasix that is wasting the electrolyte? Well, let's replace it with potassium-sparing diuretics, right? Or replace with potassium supplement. Give them IV replacement, change potassium-sparing diuretic, monitor the heart, so the EKG. Okay? One thing you have to understand is that with IV potassium replacement, we cannot just give it straight. It has to be mixed in a bag, right? So it has a secondary bag. And the concentration should not exceed 40 to 60 milliequivalent. And the rate is usually slow per hour. One thing you must never do, and PNs do not go close to this anyway, they don't give IV push. So, but potassium is never given IV push because it can cause cardiac arrest. Next slide. So now we're talking about hyperkalemia is the other electrolyte imbalance. Here you have the serum potassium level that is greater than 5. It's less common than hyperkalemia, but usually there's some type of problems with the kidneys. Patient that has kidney failure or altered kidney function tend to have that. Or those patients that are taking potassium-sparing diuretic like spironolactone, right? Diet sodas, parental potassium salt, right? So those kind of things can cause an increase in potassium level. Okay, so what do you see? Well, there's irritability, paresthesia, muscle weaknesses, EKG changes, and the changes again is in your figure 16.9c is tinted wave, irregular pulse, hypertension, nausea, abdominal cramps. So what do? Well, it depends on what the cause is, and is it mild, moderate, or severe? If it's mild, we can give something because you have a lot of potassium, right? We can try to waste some of the potassium. You can give them loop diuretics because it wastes diuretics. It wastes potassium. You can restrict the diet if that's the issue. If it's moderate, we want to give medication, and that is K-oxalate. We may give insulin and glucose because that helps pull it out, right? If it's severe, we want to give 10% calcium gluconate for cardiac effect and sodium bicarb for the acidosis. Next slide. So now we're talking about calcium imbalance. Okay, 99% of calcium is in the bone, 1% is in serum and soft tissue. Calcium works with phosphorus to form the bone and the teeth. So someone who has low phosphorus level, the calcium is going to be affected as well. It plays a role in cell membrane permeability, right? Because remember, the semi-permeability, the membranes, how things diffuse. The calcium is going to play a role in that if it's not adequate. It affects the cardiac muscle contraction. So you should think about some of the signs and symptoms that would happen if you don't have enough calcium. It also participates in blood clot, which is really, really important. Calcium too has its own regulation, like many other things. And this is affected by the body storage of calcium, right? And the dietary intake of vitamin D. So without vitamin D, calcium is not going to be absorbed, right? You have the parathyroid hormone, from the bone, usually. So this is how it regulates. It increases when you have low level. So the parathyroid hormone kind of pulls calcium in, right? When you have too much calcium, right, calcitonin is released by the thyroid to inhibit calcium loss from the bone. Right, so it's like hold off. So this is good. This regulatory systems are really good. So our first issue is hypocalcemia. Hypocalcemia is when the serum level is less than 8.8. Right? It can be caused by many different things: inadequate intake, malabsorption, right? Someone who has burn, steroids, someone who has an pancreatitis or vitamin D insufficiency. What do you see when someone has low level of calcium? Well, you see neuromuscular signs. So they are anxious, they are confused, irritable, they twitch, paresthesia around the mouth, fingers, and nose, and tensioning. All right? And you also see the neuromuscular twitching, right? It's on figure 16.8. You have the Chavarsky sign and the Trousseau sign. So the Chavarsky sign, you see this unilateral, like, the spasm of the facial muscle by, it's when it's elicited by tapping over the facial nerve, right? And then the Trousseau sign, when they put it's evidenced by a spasm of the fingers and hand and the wrist. You see it in your picture when the blood pressure cuff is inflated to a level between the patient's systolic and diastolic pressure for 3 minutes. So those are the muscle twitching that is referred to. So look at those because sometimes NCLEX would show you pictures and they want you to identify what those are. No enough calcium is going to affect the bone. Remember we talked about that. Diarrhea, decrease in response to digoxin. You will see EKG changes as well. So what do? Well, they have a low level, so we can give them calcium gluconate for post-op, client that have the thyroid or the parathyroid removed, because the parathyroid is right under the thyroid. So sometimes with surgery, they remove that as well. We'll monitor the cardiac and replace oral or IV calcium intake. All right. So the next slide. This slide is talking about hypercalcemia. Hypercalcemia is the serum that is greater than 10. Serum calcium level is greater than 10. The major causes of hypercalcemia is usually cancer. So parathyroid tumors, multiple myeloma, the chemotherapy agent that they're taking, someone who has prolonged immobilization, someone who's had, multiple fracture, and Piaget's disease. So what do you see? You see that this patient is fatigued. They may have deep bone pain, They may be constipated, muscle weakness, right? They may have anorexia, kidney stones because there's high level of calcium, and so it accumulates. And what do you do? Well, if they're asymptomatic, so we just will try to treat the underlying cause. Try to hydrate the patient, to encourage diuresis, especially to allow the stones to pass. We can give loop diuretics, we can give steroids. So we need to figure out pretty much what the cause is. Okay? So nursing management is a lot of teaching fluid and safety precaution because you don't want them to fracture their bones. Next slide. So now we're talking about magnesium. Magnesium, again, is important because it assists in the transmission of nerve impulse, activation of the enzyme system, right? And for ATP, right? So it helps to produce the ATP and helps with the function of vitamin B. It also plays a role in protein synthesis and carbohydrate metabolism. It helps the cardiovascular system by vasodilation and regulate muscle contraction. So very, very important. So hypomagnesium is when the serum level is less than 1.3. So it could be caused by many things. Poor dietary intake, poor GI absorption, and excessive GI or urinary losses. There are some folks that are at risk for magnesium problem. Those individuals, high risk, chronic alcoholism, people that have malabsorptive disorders, GI or urinary system disorders, those people that have sepsis, burns, and the wounds that needs debridement. All right, so what do you see? Well, magnesium seems to affect a lot of systems. So the central nervous system, you will see like change in level of consciousness. There's confusion. There's hallucination. Neuromuscular. There's muscle weakness. There's leg and foot cramps. There's hyperactive tendon reflexes. You will see the Shavarsky and Trousseau sign that we just talked about in the calcium section. For cardiovascular, you will see tachycardia, hypertension, EKG changes. For gastrointestinal, dysphagia, anorexia, there's nausea, and there's vomiting. Okay? So what do we do if someone's magnesium is low? Well, if it's mild, then we try to replace it with diet. If it's severe, we have to give IV or MI, mag sulfate. And we will monitor the neural status, the cardiac status, and safety. One thing you need to understand about magnesium sulfate is that a pump is used, and it's usually no faster than 150 milligrams per minute. When we give magnesium, we got to monitor for toxicity. So the vital signs that would tell you that there's toxicity is the respiratory rate and the blood pressure. So you see hypotension and respiratory distress. We have to monitor the mag level every 6 hours. We have to monitor the cardiac monitor. You see all these things that can cause. We have to make sure we have the antidote at the bedside. And that antidote for magnesium toxicity is calcium gluconate. Calcium gluconate. All right. So now, next slide. So let's talk about hypermagnesium. Hypermagnesium is the level greater than 2.1. It's not as common, and you usually see it with renal dysfunction, right? So someone who has, renal failure, Addison's disease, adrenocortical insufficiencies, untreated diabetes, ketoacidosis. And what do you see? There's decrease in your neuromuscular activity. The tender reflexes are not as active. There's weakness, there's nausea, there's vomiting. What do we do about this? Well, we increase the fluid if it's renal function. It's normal. Loop diuretics, if they're not responding to the fluid. Calcium gluconate for toxicity. Mechanical ventilation, if they're in respiratory depression. And hemodialysis. And there's different type of hemodialysis, the dialysate. So make sure that it's the one that does not have magnesium, because if they have too much magnesium, we don't want to give them more magnesium, right? All right, so next slide. So this slide is talking about a question. It says, which of the following intervention will be appropriate when caring for a client that has hypercalcemia? Because remember, we say the calcium stones can form, so it's not bed rest. They have too much calcium, so you're not going to give them calcium supplement. They didn't have an infection, so you're not going to give them antibiotic, but you're going to encourage fluid. Slide. So this slide is giving you the rationale, because hypercalcemia is a condition in which the serum calcium is elevated. By providing an increased amount of fluid, calcium excretion is promoted and the amount of circulating calcium will decrease. Next slide. Now we're going to talk about the acid-base imbalance. All right, so now we're talking about acid-base imbalance. Acid-base depends on many things. So the regulation of free hydrogen ions. It depends on the concentration of ions. It is measured in pH, right? We also need to assess acid base using arterial blood gases. So these are the major diagnostic tests, because this is a function that is done not by the nurse, but by the respiratory therapist, or the physician is able to draw blood from the venous. So the arterial blood gases, when we examine them, we look at the pH. Normal pH for the blood is 7.35 to 7.45. Okay? And then you see the CO2. It is 35 to 45. You should be looking at those two and says, oh, they kind of look alike. If I drop the 7, then you have 35 to 45. So that's one way to remember it. Right? And then you have the bicarb, that is HCO3. And the normal level is 22 to 26. Just like with all the other acid-base imbalance, you learn like the range. You learn the normal range, and then with this this section, you want to see less than becomes something, more than becomes something. It's either hyper or hyper. In this case, acidosis or alkalosis. Okay, so acidosis is defined as the pH is less than 7.35, right? Because remember, you have that pH scale, that acid scale from 0 to 14. 7 is neutral, and then anything less than 7 is acidic. But the blood, anything less than 7.35 is acidic, right? So the lower that number, the more acidic it is. Like the stomach is really low, like 3 something, but that's why the stomach is coated with a mucus to help protect it from its own acid, right? So again, the definition of acidosis is pH that's less than 7.35, but then it's because usually there's an accumulation of acid or a loss of a base. So when you look at those normal pH I told you about, a CO2 that is high, that's considered acid. A base that is less than the normal, 22, that is considered a loss of base. So that is acid. Right? Alkalosis, by definition, is a pH that's greater than 7.45, right? And this occurs when the base accumulates, so that HCO3 accumulates, so it's more than 26, or a loss of or a loss of an acid. So that pH, that CO2 that is less than 35, that is loss of an acid, if you want to think of it that way. Okay? So there is regulatory system here as well. Just like the other things, the body tries to regulate itself before it goes to the point where it can't compensate anymore, right? So three systems into play when the pH rises or falls. So if the pH goes up or falls, these three systems take place. The first one is chemical buffer, right? The second one is a respiratory system, and then the third is the kidneys. So let's talk about each of those. So a chemical buffer, and this is like the immediate acting one, right? What you see is combined with the acid or the base to try to neutralize the effect until the other system takes over. So bicarb, that bicarb HCO3, it's mainly responsible for buffing the blood and the interstitial fluid. So phosphate buffer is also there, and that is in the renal tubules. And then you have the protein buffers. So, and that's the most plentiful, and it's in hemoglobin, right? So these are the chemicals that try to neutralize, the acid, okay, or try to compensate for a rise or fall of acid. Those are immediate acting, right? And then you have the respiratory system. So now, okay, the lung is going to work. And so the CO2 and water, H2O, create something called carbonic acid, right? So the lung is going to regulate the blood levels of CO2, right? The lung, that's what it does, right? So it creates carbonic acid by the CO2 and the water forming. So high CO2 level, what's going to happen is there's slower breathing. It holds on to the carbonic acid and lower pH. When there's low CO2, there's faster breathing. A blow of carbonic acid and raises the pH. This is twice as effective as the chemical buffer. But it's also temporary, it's not permanent. All right? And then the third person takes over, the kidneys. Reabsorption to excrete excess base or acid in the urine. It produces the bicarb. It takes, because this is happening in the kidneys, it takes hours to days to accomplish. So the bicarb level and the pH levels increase or decrease together to try to compensate. Again, the arterial blood gases, we use the blood from an arterial puncture, so you can do it from the radial artery. So it's an artery, it's not the vein. And when we do the test again, we're trying to look at the pH, the CO2, and the bicarb. So what I would like to do right now is to try to help you interpret the ABGs. So when you see it on an exam, if you see it with your patient, you'll be able to say, oh, this is what's happening with the client. So there are 5 steps or things you need to follow. The first one is to check the pH. Okay? Check the pH. All right? So when you're checking the pH, you're going to look and say, is the pH less than 7.35? If it is, then that's acidosis. And then the next thing is the pH greater than 7.45? If it is, then it's alkalosis. All right? So once you figure that out, and then you move on to the second step. The second step is looking at the CO2. What is the CO2? So the CO2 gives you information about the respiratory component of the acid base. So the CO2 tells you the problem is within the lungs, right? So if abnormal, does this change correspond with the pH? All right, so if the CO2 is abnormal, does it correspond with the pH? For example, high pH, you expect to see low CO2, because that means high pH is alkalosis, and the CO2, a lot of CO2 tells you acidosis. So yes, that does. low pH, you expect to see a high CO2 because low pH is acidosis and a high CO2 is acidosis. And then step 3, now you look at the bicarb. The bicarb. So the bicarb, that HCO3, that gives you information regarding the metabolic aspect of acid-base, not respiratory. Because remember, you have either respiratory or metabolic. Those are the two acid-base imbalances you have. So if the pH is high, always, you know, when you said when the pH is high, it means acidosis, right? Then you know that if the pH is high, you're going to know that the bicarb is going to be high, because high bicarb is alkalosis, because bicarb is a buffer. So the more of it, it's alkalosis, right? So high pH, bicarb expected to be high. If the pH is low, expect the bicarb to be low, so less than the 22. Right? That's step 3. Step 4, now you're going to look, is there compensation taken on here? Remember how we talk about the 3 different things that are going to take place, the chemical first, and then the respiratory, and then the kidneys, right? So if a change is seen in both the CO2 and the bicarb, a change, so whatever the results are, and then you see a change in both of the bicarb and the CO2, then compensation is trying to happen. So for example, right, and when you see, you know that compensation is taking place because there's an opposite. So metabolic acidosis, you're going to see respiratory alkalosis. All right, and then step 5 is look at the O2 and the O2 sat. So the O2, PO2, reflect the ability to pick up oxygen from the lung. O2 sat less than 95% is inadequate oxygenation. So low O2 indicates hypoxemia. Okay? So now, there are 4 acid-base imbalances. There are 4 of them. There's respiratory acidosis, respiratory alkalosis, metabolic acidosis, and metabolic alkalosis. So let's start talking about each of these. All right, so we're talking about metabolic acidosis, and then we'll talk about metabolic alkalosis, because I think I advanced the slide before time. All right, so metabolic acidosis, again, is characterized by a gain of acid, a loss of base. All right, it's usually associated with some type of ketone loss, right? Ketone, so someone who's starving, someone who's an alcoholic, someone who has diabetes mellitus. Other causes, lactic acidosis from shock, heart failure, pulmonary edema, hepatic disease, seizure, or any strenuous activity can cause metabolic acidosis. So what do you see? There's confusion, there's a dull headache, there's decrease in deep tendon reflexes. You will see signs of symptoms of hyperkalemia, such as abdominal cramps, EKG changes. You see Kussmaul's respiration, lethargy, there's warm and dry skin, there's hypotension. So what are the ABGs of metabolic acidosis? So what you see when it's not compensated, the pH is less than 7.35, because we're saying it's acidosis, right? The CO2 will be normal because that's not the issue here. This is a metabolic problem. But the HCO3, the bicarb, will be affected, right? Because it's acidosis, so you expect the HCO3 is low. If compensation take place, this is what the result you will see. The pH will be normal. the CO2 will be less than 35, and the HCO3 will be less than 22. Okay? So what do you do? Well, with diabetes ketoacidosis, they need insulin, right? So you give them insulin to reverse the DKA. You can give bicarb to correct the acidosis. Fluid replacement. You know, we may have to do dialysis for any drug toxicity, you know, because diarrhea can cause metabolic acidosis. Because remember, the stomach has acid, right? But the intestines it's more alkalinic. So when someone is having diarrhea, and just know that because the intestines are alkalinic, so if I'm having diarrhea, I'm getting rid of base. So what is left inside of me is acid, metabolic acidosis. So anti-diarrhea drugs would help with that. Metabolic alkalosis, you know, this is commonly associated usually with hypokalemia from maybe diuretic use, right? Excessive bicarbonate containing drugs, from gastric suctioning, from vomiting, because remember the stomach has a lot of acid. So when someone vomits, they're going to get rid of all the acid. So what's left inside is base, right? So what do you see is anorexia, confusion, hypotension, hypertonic reflexes, decreased respiration, twitching. So what would the ABG results look like? Well, if they're not compensated, you're correct when you say the pH will be greater than 7.45. The PCO2 will be normal, and the bicarb will be greater than 26. All right, in compensation, the pH will be normal. The the PCO2 will be greater than 45, and the bicarb will be greater than 26. So what do we do for this? Well, we can give IV ammonium chloride. We can discontinue the diuretics. We can discontinue the suctioning. We can give them antiemetics so they can stop vomiting. Next slide. So now we want to talk about respiratory acidosis. So respiratory acidosis, here you have any component in the breathing can result in respiratory problem, respiratory acidosis, right? So when someone is hypoventilating, right, they're not breathing in fast, so the CO2 is maintaining, so they have the carbon dioxide builds up, and the pH is going to drop because it's acidosis. This can result from many things, you know, something in the brain that depress, you know, the respiratory center, drug overdose, right? Lung disease, so someone who has COPD, you know, head injuries, you know, somebody who has asthma, right? Those kind of things. Who is at risk? People that have status post abdominal surgery because they're not taking in deeper breaths. Someone on mechanical ventilation, someone who's taking analgesics or sedation, right? What do you see? There is apprehension, restlessness, confusion, tremors, decreased tendon reflexes, diaphoresis, you know, they're nauseous, they're tachypneic, tachycardia, right? So the ABG result, when it's done, you can tell that it's not compensating because the pH will be less than 7.35. The PCO2 will be greater than 45. That tells you acid, and the bicarb is normal. If it's trying to compensate, pH will be normal. The bicarb will be greater than 45. And, the CO2 will be greater than 45 and bicarb will be greater than 26. So what do? Well, we try to figure out what's causing this. Is it because the patient was overdosed with some narcotics? If they are, we'll give them the antidote, Narcan. Do we need to open up the airway? So there's bronchodilators. We'll give them oxygen. Is it a potassium problem? So treat the hyperkalemia. If it's an infection problem, give them antibiotic. We can do chest PT to remove all the secretion. If it's airway obstruction, we do, the necessary protocol. All right, next slide. So now we're talking about respiratory alkalosis. Respiratory alkalosis, mostly it occurs from hyperventilation, right? Hyperventilation. And usually there's pain, from salicylate poisoning, from using nicotine, maybe they're anxious, they have fever, they have an overactive thyroid, right? Or the brain center, the respiratory center is overstimulated. So what do you see? Well, anxiety, restlessness, dyspnea, in the rate and the depth. You could see changes in the EKG, hyperreflexia, paresthesia, tachycardia. And what would the result look like? Well, we said this is respiratory alkalosis, so the pH will be higher, right? And the CO2 will be lower, right? But the bicarb will be normal, right? If it's compensated, the pH will be normal, right? The bicarb, the O2, CO2 will be low, but the bicarb will be low because it's trying to compensate, right? And what do? Well, let's figure out why they have the problem. Is it because they're hyperventilating? If they are hyperventilating, they give them a paper bag to rebreathe, give them oxygen for hypoxemia, give them sedative meds or anti-anxiety drugs because of their anxiety. All right, so next slide. So this slide is talking about a question. It says, which acid-base disturbance would be most characteristic of someone who has a narcotic overdose? So you know that this is not a metabolic problem, so you're going to remove A and B. It's not a metabolic because it doesn't have to do anything with starvation, ketone body buildup. It's not talking about somebody having diarrhea. So anything usually the butt or the mouth, it's usually metabolic stuff. So it's none of that stuff. So we remove that. So we're left with respiratory. All right, so it's either going to be B or D. So now the question is, if I have overdose, if someone is overdosed, what's going to happen to the vital signs? So the respiratory rate is going to be low, right? So which means they're not blowing off the CO2. So if you're not blowing CO2, and based on what you've just learned, a lot of CO2 is acid. So now knowing that, then you look at your choices B and D. Well, acid is B, not D. Next slide. So this is the rationale. A narcotic overdose shows the rate and depth of breathing. This leads to retention of CO2, which is an acid. So hypoventilation problems will produce respiratory acidosis. This ends this fluid and electrolyte balance lecture.